Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. My name is Kelly Gear-Ripken, National Chair of A Woman's Journey. Join us for an empowering and educational morning, Saturday, November 13th from 10 a.m. to 12:15 p.m. I'll be hosting a virtual women's health program featuring 10 Johns Hopkins medicine experts. Learn about reducing inflammation through food, memory loss, cosmetic procedures, colon cancer in African American women, fertility, mental health, and more. Take charge of your health and the health of those you love. Registration is $25. Register now at hopkinsmedicine.org/a-woman's-journey. Thank you, and now I invite you to listen to A Woman's Journey's monthly podcast featuring your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, we are talking about the use of artificial intelligence, otherwise known as AI. The pandemic has brought to the forefront telemedicine and digital healthcare. We are joined today by Dr. Mathias Unberath, an assistant professor in the Department of Computer Science at Johns Hopkins University, with affiliations to the Laboratory for Computational Sensing and Robotics and the Malone Center for Engineering in Healthcare. Welcome, sir.
Thank you very much for having me. It's a great pleasure.
So the idea of artificial intelligence first came about around 1950s with scientist Alan Turing. Today, though, it is common to have an Alexa or a phone that opens based on face detection or recognition technology. Artificial intelligence is in apps that provide us with step-by-step driving directions and in the social media platforms that we use. Doctor, where else does AI play a role when it comes to medicine?
AI technology has played a large part in medicine for quite some time. And since recently, about 2012, since we're seeing this increased interest, clinicians and technologists alike see many more opportunities to change healthcare for the better. And we see an impact of AI in healthcare, particularly in research, but slowly transpiring also into patient outcomes across the whole spectrum in healthcare, from drug discovery to patient triage, all the way to how patients are being treated in rehabilitation and so on and so forth. And I hope we'll have the opportunity to discuss some of those advances in the remainder of this podcast.
And so robotics is probably a good example of AI, and some of our audience may be a little bit familiar with that. Can you comment on how that is used and what your experience has been, particularly as it relates to what's available at Johns Hopkins?
I think robotics in general is a terrific example, and robotics in and on itself, even without AI technology in the background, has made tremendous advances in healthcare and how we deliver a surgery, for example. Hopkins has very strong presence in the use of surgical robotics and in the development of novel surgical robotic approaches to minimally invasive surgery. And that is already quite a feat for the patients. Now, there are certain open problems that arise when we think about robotic and robotic mediated surgery, which is the fact that this is a new technology and we need to train clinicians to learn and master this technology before they can actually use the technology on patients. And this curriculum on how we train physicians in the use of this new technology, for example, has been studied quite substantially with the use of artificial intelligence. We are trying to understand how trainees master technical skills as they progress through the curriculum of learning robotic technology, for example, understanding whether they master the certain gestures that they need to perform when they throw a suture and when they pass the needle from left to right. This artificial intelligence technology with which we interpret either the images that are being acquired during robotic surgery or directly the robotic data, kinematics data in and on itself, allows us to quantify skill, which is something that otherwise is very difficult and potentially nearly impossible. And this quantification really allows us to understand where a trainee needs to improve their skill, and we can target the training curricula on a personalized basis, which is certainly exciting.
I think that physicians that are in medical school currently probably have a little bit of an edge versus someone who, let's say, is in their 50s or 60s because they grew up with apps. They grew up with cell phones. They grew up doing games on the television that kind of gave them an early view, early experience with what this type of technology might be able to accomplish in the future. I said to a friend of mine yesterday, she's going to be a grandmother in the next couple of days. And she said, I can't wait to see him. I'm going to be in the birthing room when he's born. And I said, don't be surprised if he comes out already with an iPad or something and using his thumbs, because I feel like that's almost how it's happening with children so very, very young. When we look at doing imaging studies, let's say CAT scan, PET-CT, MRIs, we rely on a radiologist to be an incredible expert at finding the needle in the haystack and understanding what that needle is. I'm aware that we've been using AI to help guide physicians in figuring out where is the needle and what that needle might be. Can you talk a little bit about that and how we are able to use this type of technology as a helper and a guide? I think it's so important. We are blessed with specialists at Hopkins, but most institutions are not. So they may have a general radiologist reading an image for which that's not where he's an expert, frankly. But if he can get some help with technology, then there's a better opportunity for coming up with an accurate diagnosis.
Radiology is, of course, the prime example for the use of contemporary AI technology. And that is because, in contrast to other data that you may encounter in healthcare, images such as CAT scans or MR scans or X-ray images, for that matter, are ordered. They are stored as a grid. And as a consequence, they lend themselves directly for computational analysis, for example, using an AI algorithm. And that's why we have really seen most of the use cases in exactly this specific area, where we're trying to learn the mapping between certain patterns in our input image on that grid and what that means in terms of a clinical diagnosis, which is exactly the problem that you were just describing. And in that case, I think the biggest benefit that we're seeing is exactly the fact that these systems that we're now able to develop based on tremendous amounts of data that experts like the ones at Hopkins or elsewhere have annotated in cumbersome and laborious times, going through all the slices and annotating the presence or absence of certain findings, that we can now use to develop these pattern recognition systems that allow us to very quickly analyze and screen those data for the presence or absence of the patterns that we have learned are correlated or associated with a certain disease. And that is useful, not necessarily to replace radiologists, which is the sentence that always comes up, but solely from the perspective that by using an algorithm in addition to a radiologist, we more or less get a second opinion for free. And doing this in a synergistic manner allows us to essentially amplify the capabilities that our highly trained professionals already have. The additional difficulty that we have here is that in healthcare, there are findings, some pattern on the image in a CAT scan. But this finding is not necessarily enough to give you a proper diagnosis. So even if we are able to perform the finding of patterns with very high accuracy on CAT scans, by no means are we close to getting a diagnosis, simply because many diagnoses cannot be found from imaging data alone.
How about for a pathologist who's trying to make a diagnosis based on having tissue samples and slicing and dicing them, looking at them under the microscope? I've always said that when it comes to, for example, a diagnosis of cancer, and specifically what kind of cancer, the pathologist holds all the cards, because we make the treatment decisions, all of those treatment decisions, based on the results that that pathologist gives us as to what kind of cancer is this, what subtype is it, what prognostic factors does it have, et cetera. And not all institutions have pathologists that specialize in a type of cancer. It might be a general pathologist that looks at everything that comes into the pathology lab. So how is AI used in that type of a setting to help to guide and help a pathologist, particularly those that are not specialists?
There are various approaches on trying to assist pathologists in this specific way. One approach that I found interesting, because it describes a system, not only an algorithm, is a system that was proposed and described by Google that essentially uses these whole slide images, the tissue samples, and analyzes them computationally to identify in augmented reality visualization the contours of regions of interest that the pathologist should definitely not miss in their analysis of that tissue slide. Now, that is very interesting. It doesn't necessarily automate the whole process from interpreting the image and giving a recommendation, but it is an assistive technology integrated into the microscope. Then there are other approaches that attempt to standardize the way how we report on digital pathology reads. For example, by trying to quantify the mitotic count in breast cancer to give an estimate of the aggressiveness of that specific cancer. And then even further, and this is now work that I am doing with a collaborator, Alvin Liu in Wilmer, we are trying to predict the gene expression profile of certain cancers only from imaging data. And it turns out that is possible, which then in turn enables precision medicine approaches and follow-up and treatment that is determined for that specific patient simply because we can understand the mechanism of disease better, solely based on imaging and sophisticated analysis using AI techniques.
So you mentioned Wilmer. Are these cancers that affect the eye?
So in this specific case, we are looking at uveal melanoma, which is the primary ocular tumor in adults. And we have a very strong collaboration here because Hopkins used to see relatively many patients for this overall still rare disease.
That's fabulous. That's absolutely fabulous. Where else do you see precision medicine and AI married?
Ophthalmology is certainly one of the leaders in this space, simply because the way how they acquire data lends itself very well to the analysis using AI algorithms. Fundus photographs, for example, OCT data, all are required for a very long time. So they have lots and lots of data. And at the same time, the imaging procedures are non-ionizing in contrast to, say, X-ray, and they don't take an hour in contrast to, say, MR. They clearly have an advantage. And also at Hopkins, the Wilmer now has an AI effort dedicated to the advancement of these methods, with Alvin Liu, the collaborator of mine that I previously mentioned, now being the director of that effort. And I have other collaborations with faculty in that department too, which is very exciting. But really, we're seeing interest across the board, across all medical subspecialties, and every provider is very interested in improving the outcomes of their patients and helping them treat their patient population better. So me and my colleagues in the engineering school, we have lots of requests, more than we can cater to most of the time, of interested clinicians who want to work with us in order to improve patient care at Hopkins. And we see such approaches come to fruition in radiology. We see some early approaches also for improving image quality in image-guided surgery, but really across the board. I could find examples everywhere.
That's fabulous. Are you personally involved with any clinical trials that would be comparing the use of AI versus not using AI in clinical care?
Currently, the research that I am involved in is not yet at the stage where we could go for clinical trials. We have done some comparative studies where we try to benchmark AI algorithms to reads or consensus reads and diagnoses from a group of clinicians. And of course, also we are seeing that they perform approximately comparably, or AI even outperforming the group of clinicians. But I think that, as I said, my research is not quite there yet. And there are lots of challenges that need to be overcome in order for research in general to get to the stage where it is ready for prime time in clinical testing.
What about guiding population-level disease prevention? So we want to see a lower incidence of diabetes, a lower incidence of COPD and heart disease and such, which become, as you know, chronic illnesses and eventually usually the cause of death. Are there ways that AI can be used or is being used to focus on lifestyle behavior changes that hopefully would result in people not having these types of chronic illnesses, and as a result having not only better quality of life, but better quantity of life as well?
That is, of course, a very exciting area, but I think that companies are currently leading the charge in that regard simply because they have such a good perfusion of the market. So if you see, for example, the Apple Watch that is worn by so many people, being able to use these wearables and data acquired by those wearables for public health interventions is a very interesting approach. And I think just recently, the Apple Watch was FDA cleared to detect cardiac arrhythmias, and which is certainly an approach that has lots of perfusion. Many people will benefit from this technology, but there are even much simpler interventions functions that you can do based on wearables, which is this little annoying reminder to stand up every once in a while if you wear an Apple Watch because you've been idle for too long. And things like that have the opportunity, of course, using algorithms of varied sophistication to tell you and invoke a certain desirable behavior in people that use these wearables, for sure.
Yes, prompt you to do something good for yourself, right?
Yes.
And we see commercials on television for individuals that have diabetes and they're trying to figure out, well, what can I eat? I'm now in a restaurant sitting down here and I'm looking at the menu and I don't know what my blood sugar is right now. And yet they can, because they've got a device that goes to their cell phone and tells them what their blood sugar is and over time what the pattern has been, et cetera. We're moving into this area, perhaps not even realizing in some cases for patients that they are using AI. I don't know that they may necessarily understand that is what these devices, just like a pacemaker for many, many decades ago, right, when we started using them. But I'm a firm believer, whatever can help us to be healthier is probably a good thing. And if it is a prompter, or some method that might be a little annoyance, but we still know the importance of paying attention to it, it really can improve patient care and improve health overall for the population. What are some of the concerns, though, that we need to be aware when it comes to AI in healthcare?
So this is where a lot of research right now, I think, has to pivot to, and is to really understand how we can translate the research successes that we have been seeing and that is driving this recent hype and interest in AI, and how we can translate that hype and those advances into true patient outcomes. A lot of it is missing from achieving exactly this. One issue, for example, that we're observing is the fact that algorithms can be biased. That is a problem that we have across the board. Not only algorithms are biased, people are biased too. And that turns out to be the root of this problem, because we are developing algorithms that mimic people. And if we have a system or decision makers that make decisions in certain ways that are undesirable, the algorithms that we develop based on those data generated using that policy will be no better than what they tried to mimic. And I think that right now we have strong incentives in the community that try to increase the diversity of stakeholders in AI research in order to have more open and more upfront conversations around what we can and what we must do in order to promote equitable access and equitable outcomes after the use of AI for all sorts of technology. This, of course, when it comes to healthcare, but this transpires even into consumer products where AI is already, as you said in the beginning, in everybody's cell phone. So we need to understand how we can deal with these types of problems. Another issue that is equally interesting is the fact that since 2012, the reason why we talk about AI is because we have seen that more and more complicated problems can be solved using the technology that we have developed. And that, of course, is exciting. But a lot of the recent research is driven by increasing performance. And as we stall on that front, I think we need to look back and see not only how can we solve problems with high performance, but also how do people want to interact with this technology? How can we interface this technology that solves certain problems with superhuman accuracy? How can we interface that with people who need to interpret these results, contextualize them, and ultimately make a decision for which they can be held liable? This involves human factors. This involves engineers. This, of course, involves the subject matter experts like clinicians. So really now is the time to synthesize teams that have varied backgrounds, both with respect to diversity in cultural and ethnic background, but also with respect to academic and intellectual backgrounds, to bring them all to the table and understand how we can translate the research successes into products that achieve what we want to achieve as a society in healthcare.
That has to be really complicated to, in essence, rid ourselves of subjectivity, whether it be reading an image or reading a pathology slide or developing an opinion that results in a standard of care. And I appreciate the fact that we do need to have diversity in looking at ethnicity and culture and factoring those things in to this process as well. So when we look at how we see AI today, obviously it's going to evolve over time. If you had a crystal ball, and you might, I don't know, where do you think healthcare will be with artificial intelligence, say 20 years from now, that next generation?
That is a good question. Unfortunately, I do not have a crystal ball, but I certainly hope that we will have moved a bit away from the narrow perspective onto AI that we have today, where we try to automate certain subtasks and do that with superhuman accuracy, but move to a more holistic perspective of how this fits into treating patients. And this involves exactly what I was talking about earlier, trying to understand how humans interact with this technology, and then understand also how we need to rethink some of the healthcare that we are providing. Because as we see that AI becomes a tool that allows us to look at some of the clinical problems, some of the clinical decision-making problems differently than we did it before, maybe also the way how we deliver healthcare changes from this provider-centric approach where we have an office somewhere located downtown to something that is a bit more distributed and more accessible for people that now don't have to necessarily live in urban areas, but they can live everywhere and still receive the same level of care, for example, through remote visits. And I think that there will be a whole lot of opportunity to rethink the way how we deliver treatment and how we deliver the highest level of healthcare in settings that are different from the settings that we currently have envisioned for ourselves.
Something I'm particularly interested in is what we call patient-centered care, but I don't think that it always is accomplished. So when I say patient-centered care, I'm talking about this patient is more than their disease or disorder. Is this a person who had a life before they got diagnosed with something, and we want them to still have a life and hopefully a good life during treatment and after treatment? So being able to potentially use AI to figure out how does this individual make decisions? Because we assume that everybody does that the same way. You lay out, here's 3 or 4 choices, and I'll tell you about each of them and the pros and cons of each, and then you pick one. And that isn't necessarily how it works at all. It's what that patient's prior experience with things, whether personally experienced or with a family member, et cetera, certainly does play a big role into how they're going to participate in the decision making, or even if they want to participate in the decision making. The other, I never want to have a patient have regret regarding the choices that were made about their treatment. I think that's one of the worst things that could happen, is for a patient 10 years from now to say, if I had only understood thus and so better, or if I had only realized X, Y, Z, I would have chosen differently. I would have spoken up. I would have whatever. And therefore that person has regret. And then the third is understanding how a patient defines their quality of life. If we ask a patient, are you doing your own activities of daily living? Yes. Are you eating? Are you sleeping? Yes, yes. But we aren't getting into are you sleeping well? And that's based on his or her definition and not on ours. Do you have joy every day? What are the things that give you joy and bring you joy? So we really need to dig in so much further than what we usually do, just focusing on that disease or disorder, and realize this is a life, and let's meet them where they are and not try to drag them to where we are, so that we can truly deliver patient-centered care. Do you have any feedback for me on that?
I think the picture that you paint is very exciting and empathetic towards the patient, which I think is just the right way to go. When we think about AI in this specific use case, however, I am afraid that I will have to disappoint, because while of course we see these reports of very high capacity language models that are able to write texts that fool people into thinking that they would be human written, these texts are in a way recreated from large amounts of texts that system has interpreted beforehand and has learned to reproduce in non-trivial ways, which of course is a great accomplishment in and on itself, but it is far away from understanding what something like good sleep means to a person and how that needs to be interpreted in context of a disease and treatment options. So this high level of reasoning is something that we haven't been able to do, and in part because once you think about it this way, you suffer from something that is called the curse of dimensionality, in that this becomes so personal that the amount of options in every single one of the dimensions that you have are infinite. And seeing enough samples in order to recognize patterns and in order to reason on top of those patterns then becomes impossible, at least using our current understanding of this technology. And there, I think, as you paint this picture of a world where AI becomes indeed patient-centric, I think we have a whole lot of work to do on the engineering front.
Well, I'm an optimist when it comes to that, and certainly an optimist with the achievements that Johns Hopkins Medicine can accomplish. And I will predict for you that 20 years from now, you and I may have another conversation about this. And perhaps you'll be able to say to me, look at what we're now able to do in delivering a better patient-centered care than ever before. So thank you so much for joining us today, Doctor, and keep doing what you're doing, because we certainly do need experts like yourself who can think out of the box and perhaps further into the brain to be able to move us forward so that we can benefit from this type of artificial intelligence. So thank you.
Thank you very much for having me, and I'm definitely eagerly looking forward to that conversation.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.